And since I am safe distance from people and we don't really have too many people in the live audience, I'm going to take off my mask so you guys can hear me. So, of course, since last year, 2020 particularly, we've been affected by COVID-19. Like it or not, worldwide, everybody's had some contact with it. And so recently, of course, as you know, there's been, a resurgent of the virus. And so there was lots of questions being asked about it as we were, in the prayers halls and outside and everywhere else. So we thought that it might be a good idea to actually put something together for our audience and our local community, as well as, I think, perhaps in some ways, worldwide community, because I do know there's people actually watching from Pakistan and whatnot. Okay, so I'm going to do this. It's essentially a two-parts scenario. I'm going to really cover the anatomy of the virus, and then Dr. Imran Sharief is going to cover the clinical aspects of the virus. So, and if you have any questions, at least in the audience, you can raise your hand. Otherwise, if you have questions after this and you want to know more about it, then you can certainly go to IIOC.com and post your questions there. So just quickly about myself, my name is Sana Khan. I'm by profession, I'm a radiologist. So that's my medical training and my PhD degrees. Actually, I have a PhD in anatomy and a PhD in clinical neurophysiology, which is just brain anatomy. So this is the original name that everybody kind of got to know the virus with, right? The coronavirus. But you probably have heard of some other names, right? Of course, COVID-19. You may have heard of SARS, SARS-CoV-2. Just know that these are actually just different names for the same virus. Now, today we're going to actually have some basic learnings. I'm going to talk about what is a virus. Believe it or not, most people actually don't know what a virus is, yet we all, talk about them as in a very familiar fashion. How does a virus actually attack? What made COVID-19 virus so dangerous? How does our immune system defend our body? How does COVID-19 attack the lungs and other organs? And what does viral load mean? And then flattening of the curve. And then I will hand it over to Dr. Imran for further discussions on the clinical part of it. So we are all very familiar with viral infections. This is nothing new in terms of, oh my gosh, there's a virus out there. Well, pretty much all organ systems are affected by viruses. Our eyes, our lungs, our liver. In Pakistan particularly, when you have hepatitis C, is a very, very common scenario over there that's very life-threatening. That's a virus, right? So you have hepatitis A, B, and C. Skin infections happen with viruses. STDs, HIV is actually a virus. You can have pancreatitis with the virus. So it's on and on. We're affected by viruses all the time. COVID-19 just happened to now be a pandemic, and that's why it's being looked at more carefully, although viruses are being studied for decades. So what is a virus? A virus is really a non-living organism. Non-cellular, submicroscopic. It's an infection agent that actually replicates inside living cells. So it needs a live host in order to survive. So what happens for the most part, viruses will evolve until they can survive in a host and not kill the host, because it's not in their benefit to kill hosts because they need them. So here's the picture of a coronavirus or a COVID-19 virus. You can actually see here, this is, of course, microscopic. It doesn't really have these colorful things. We see purple and red, and people color them in all kinds of different colors. But this is what it really looks like. It's 100 nanometers. It's a very, very tiny little creature, if you want to call it that. So as I said, it's non-living, and a protein coat surrounds it. And there's actually a code inside of it, whether it's RNA or DNA code. And that's genetic material which allows it to replicate. Just to give you an example, in terms of viruses, the COVID-19 virus is about 20 times smaller than the E. coli bacteria. So they're much smaller than bacteria. And if you think about a polio virus, it's about 1,000 times, just to give you some idea of it, 10,000 times smaller than a grain of rice. Very, very small, tiny little critters, but very effective, very brilliant. Don't get lost in the complexity of this slide. Let me just kind of tell you what happens. How does the virus come in, particularly COVID-19? So COVID-19, it's really a lock and key mechanism. So what happens is that we're actually surrounded by antigens all the time, whether it's a virus or bacteria or whatnot. Sometimes these viruses can actually gain access to a cell. So this here is a cell membrane, right? So our bodies are made up of cells, right? So this is a cell membrane. And so COVID-19 actually, with these spikes, is able to lock in to something called the Ace2 receptors. This is angiotensin converting enzyme type 2. The problem is this key, or this lock, I should say, because the key is actually with the virus. This lock is very common in our body. This lock exists on many, many different types of tissues, whether it's in the nose, whether it's in the mouth, lungs, heart, blood vessels, kidneys, liver, GI tract. They all have ACE2 receptors. And that is what makes COVID-19 that much more dangerous, because it can affect so many different aspects of the body. So what happens is, it says knock, knock, and ACE2 receptor says, aha, well, your key fits, let me let you in. Then what happens is, it gets access into the cell, because the ACE2 receptors recognize it. As it gets into the cell, this outer protein, this outer layer, then opens up and releases this inside coding mechanism. It's an RNA. So it releases it into the cell, and it is just brilliant. It's a brilliant mechanism, maybe some evil genius, if you want to call it that. But what it does is, this RNA essentially takes over the mechanism of the cell and utilizes the cell's own factory to reproduce itself. So what it does is, it basically starts to formulate proteins and then those proteins then start making more of these RNA, what's inside of this. And also, they use the Golgi apparatus, which is the factory of the cell, to produce this cell membrane. And then it takes this code that it has further multiplied and then encodes it into its own self, creating a brand new virus, and out it goes. So this can happen over and over and over again in the cell. And eventually, so much so that it'll destroy the cell itself, but for each cell, it may have produced thousands, if not hundreds of thousands of replicas of itself. Brilliant, brilliant, brilliant mechanism. So, and that's what's causing the problem. So how does COVID-19 affect the lungs, right? So most of us actually know about COVID-19, and it affects the lungs, and people have to go and get intubated, and tubes get put in and all that. So why is the lung so important? Why is when I told you it also is in the heart and the vessels everywhere else, right? Liver, it has ACE2 receptors. Well, because this is the entry point. The lung is actually the entry point, because it travels via air. So what happens, and again, don't get lost in this, but I'm going to try to walk you through what happens when COVID-19 virus gets into the body, okay? So generally speaking, like I said, you have healthy lungs, right? And you have something called the trachea, is the tube through which we breathe. And then it divides up into bronchus and then bronchioles. And it ends up in these very tiny little sacs, tiny little air sacs, okay? These are called alveoli. So these alveoli, the alveolus for one. So here's one alveolus, right? And this is a very, very, very thin sac. This is where you have the exchange of carbon dioxide with oxygen, right? All of us know that that's what happens when we breathe in. We breathe in oxygen, we breathe out carbon dioxide. Well, so what happens is, each one of this alveolus is surrounded by something called a capillary. Very small, tiny little blood vessels, okay? Now, this alveolus has two types of cells, type 1 and type 2. Type 1 alveolar cell actually is so thin that it allows for oxygen to flow in readily, in and out. Then you have a type 2 cell alveolus, which actually produces something called surfactant, which creates tension, keeping this tube open, keeping this little sac open. The advantage, of course, or the problem, I should say, not the advantage, is that alveolar type 2 cells have Ace2 receptors. And so when we breathe in COVID-19, the virus, okay, it actually can infect the alveolar type 2 cells. So what happens when this cell is infected? Okay, what happens is, as this cell is infected, see the sac gets infected, it cries out for help to the body. Help me, I have a foreign agent that's attacking me. So the body responds and has these defense cells called macrophages. And these macrophages come to say, okay, where is the evil outside invader? I'm going to eat it up. Well, they come, but the problem is when the macrophages come, they release something called cytokines. Okay? And the reason they do that is because that opens the vessels more, so that more defense cells can come in and attack the invader. The problem is in the lungs, when the cytokines are coming in, they're opening up the cell, fluid leaks in. So the fluid leaks in from the blood vessel into where this sac, between the sac and itself. So you can imagine if fluid leaks in into this area, this exchange becomes harder, right? The oxygen, carbon dioxide, because the distance just increased. Okay. The other thing that can happen also is something called cytokine storm. If there's too much of the infection, too much of the cell of the virus comes in, and we'll talk about that in terms of viral load, then you have something called cytokine storm, and that can be really, really bad. But let's just stay focused on this. So the macrophages come in, they're really cytokines, more fluid comes in, they're attacking now these foreign invader, these defense cells come in, but then as they're attacking this, there is actually now byproducts, right? So not only do they come in and attack, they're random. Macrophages are really mean and tough. You can actually also destroy the alveolar cells, okay? And when that happens, the sac begins to then collapse, because remember I told you the tension was formed by something called surfactant. So the sac begins to collapse. You got more fluid inside the alveolar sac. It's becoming harder and harder to do this exchange. And as it becomes harder and harder to do the exchange, people get short of breath. So what happens after that is signal, so the rest of the body needs oxygen, right? All the tissue needs oxygen. If the tissue doesn't get oxygen, it sends a signal to the body, say, we need more oxygen. How else can you get more oxygen? Well, you got to pump more blood. Well, the heart has to work harder. So people that have heart diseases have a problem, because their hearts can only work hard for a little while. So what happens now, okay, is that you got fluid in the middle between the sac and the capillaries and the blood, hard to exchange oxygen, carbon dioxide. You got yourself formation of pus in here. And if this gets really bad, this pus can then leak back into the blood vessels. And if it does that, then you got the rest of the body now being affected by massive amount of this kind of debris. And you can actually have something that people can actually go into something called septic shock, where there's infection all over the blood vessels. So this is what's really happening at the lungs, okay? So now, we have some things, the defense cells, as I was telling you about, right? So think about all of this as a battle. And as Dr. Imran will start telling you about this after a couple of slides, this battle goes on in our bodies all the time. So our body is a castle. So out here, this castle is being protected by, in our case, our skin, right? We have this outer protection. And then we have these soldiers sitting up on top, shooting down arrows at the invaders, right? The invaders coming in all the time. And then if the invaders are really big and tough, we got these massive, bigger cells, these mean, and I'll show you some of the cells that are ready to also attack our invaders, okay? So, and these are now cuter than those invaders, but let me just show you how it happens. You probably heard something called B cells and T cells. You probably heard something called memory cells, right? Well, what happens is all of us have these things called B cells, these defense cells, okay, in our immune system. And what they do is they go round and round and round and look for foreign invaders, anything that's foreign to the body. And whenever a B cell recognizes something foreign that it actually has receptors for, it can attach to, it says, aha, I got one, right? I got one. So it catches it, and then it calls for verification before it starts to reproduce, something called helper T cells. So helper T cells come in, verify that it's actually attached onto something foreign, and then helps, it activates the B cells. The B cells then multiply, but they come in two forms. One called a plasma cell, the other is memory cell. The plasma cell replicates some things called antibodies. You've probably heard of that. So antibodies are these, so instead of like this whole cell having to attach to the antigen, these antibodies are produced, so these B cells produces these tiny little attachments. So instead of producing the whole cell, just these attachments that can fit to the foreign invader are produced. When it does that, now it's tagged. All of these are tagged, so they can produce hundreds of thousands, if not millions of these antibodies. Now it does that. As soon as these invaders are tagged, these big, tough-looking, bigger cells, or eater cells we call them, will come in and start eating away at everything that has this tag. So that's the initial response. Then you have something called memory cells. Remember I told you they form memory cells? So what happens is the body then produces lots of these memory cells. So instead of one cell going around trying to fit itself into this, now we've got hundreds of thousands of these memory cells over all of the body. And as soon as this invader comes in, it's no longer a new invader. It recognizes from back here, because now we have 100,000 agents looking for it, identifies it, immediately mounts a response, gets the antibodies done, our big, tough immune cells come in and eat away at those. And that's immunity. That's what immunity is all about. It's an early recognition of the invaders, because our body needs time to fight. And if our body is here, if it can identify earlier and knock it out, fantastic, right? Because we can knock it out. If it gets to be, it takes time, 2, 3, 4 days to recognize and identify and multiply the defense cells, the invaders may have already gone all the way out here and gone overwhelming the defense system. So that's what's really happening. So there's two concepts I want you to fully understand, and the reasons that masks are important, okay? And other aspects of defense are important. So I get this, you know, sometimes like people argue about vaccines or not vaccines, the mask, not masks, but listen, just wear the mask and stop arguing about it. It's going to help, okay? How does it help? Well, basically, remember I was telling you it's a castle that you're dealing with? So why is it that in a war that you've probably all seen Lord of the Rings, right? All those big slings that are coming with those big stones trying to knock down the wall? Because the castles are built so that there's only a small entrance. So the foreign invaders can only come through a small entrance, only 200 soldiers at a time. Your defense of 10,000 soldiers, easy peasy. 200 is no big deal. They come in, you knock them out. But the reason they're trying to knock down the wall is because they got 100,000 soldiers outside the wall. They want to be able to send in 1,000 to 2,000 to 3,000 soldiers at a time. That's why they need to knock down a wall of the castle. Because that what happens if the castle wall is breached, boom, you can send in a lot of invaders. Same thing happens here. When someone actually has the virus, they're carrying the virus, and they cough, or they sneeze, or even talking regularly, but what happens is not only do you get, if they're just normally breathing, maybe a small amount is coming in and out, but if they cough or sneeze, they're throwing missiles out. Missiles, those big boulders are coming at you. And when that happens, your viral load can become really, really high. And if your viral load is really, really high, your body's ability to defend itself becomes very difficult. Okay, it has a difficult time defending because so many of its cells are infected because of the large amount of opposition soldiers that are able to come in. So masks really help because not only somebody coughing, you block those big droplets that are the missiles. Somebody breathing those in also cannot be affected by the big droplets. A small amount of virus coming in is okay. Your body will handle it. Now, why do I say it's okay? In fact, it might even be better. Because I tell you one thing right now, all of us are going to be exposed to COVID-19. COVID-19 is here to stay. Don't think that it's going away. Don't think it's going to disappear next year or the year after, whatever. It's here to stay. It's a virus. We just have to get better at defending ourselves, and our bodies will adapt to it. But my point being is that you want to minimize the viral load coming in at one time. That attack at one time you want to decrease, so that your bodies can knock it out, form the memory B cells, and be happy campers. That's why a majority of the people that get COVID-19 are not going to get sick. 80% or so will never even know that they got exposed because they're healthy, they got small exposure, and they're okay. So here's the concept of flattening the curve. You guys may have heard about this, but a lot of people don't understand what this really was, the significance of it. Very simple. As I said to you, all of us are going to get exposed. So imagine if there's a population of 2 million people and they're going to get exposed to COVID-19, all of them. Okay, or let's just say 1 million of them before we reach herd immunity. What happens is that what we're really trying to do by flattening the curve is trying to minimize how many number of people in one time get sick. Because if 1 million people get sick all within a very short period of time, our systems get overloaded, our healthcare system, our capacities get overloaded, and people will have trouble surviving without the proper care. So what you want is that 1 million people not to get virus within 3 months. You love to have, not love to, but you prefer to have that same million until we reach herd immunity to get it over 2 years. So our systems can survive and do okay. And we can fight back and give scientists time to figure out what to do, to come up with the different types of mechanisms, whether medications or vaccines or whatever, right? That's what flattening the curve means. That means the same million are going to get it before we get herd immunity, but you want to do it over a longer period of time. Okay? So, having said that, Imran bhai, you're up. So I'm going to make a proper introduction to Dr. Imran Sharief. Mashallah, he's a pulmonologist, a critical care specialist. We're lucky to have him. Mashallah, he's on CNN and Fox News, and I don't know, should I have said Fox? Probably we shouldn't have said Fox. Okay, but CNNBC and all those stuff. Mashallah, he's an expert. He's in this disease and is always trying to teach and educate us and our communities. So really appreciate having you here, and please take the mic and educate us some more.
Thank you. Thank you, Sana bhai, for the kind introduction. And it's a pleasure to be here. So let's see. Let me just make sure that it's working okay. Okay. All right. So first of all, let me take my mask off so I can talk, and we are social distancing. So it's a pleasure to be here, and I really want to appreciate the invitation from Dr. Sana Khan. He's an expert in his field, which is clinical anatomy, radiology, and a lot of other things that he does. And we have been on media and multiple other shows together talking about the same topic or different topics. So he's an expert, I would say, in most of the fields. So thank you. So this is an interesting disease. Means I am a pulmonologist, and this is a disease of lungs. And this is going to stay here. And this virus is going to keep changing and keep mutating and coming up with new names and new issues, new challenges that we have to deal with. I have been practicing for more than 20 years, and I've never seen anything like this. I've never seen anything causing so much damage to a human body. Initially, when the pandemic started, it was the pandemic of people who had multiple health problems, who were elderly, and our ICUs were full, hospitals were full. There were tents outside, made up hospitals. Now this has changed. We got the vaccine, which was kind of a little bit became available in 2020, end of 2020, and now it becomes the pandemic of the unvaccinated. And in our ICU, average age at this time is between 38 to 42. So I have patients who are as young as 25 and 26. I have patients who are as old as 52 and 55. So we don't have any patients who are 80 or 90-year-old, which we were seeing initially. So with that, Dr. Sana really presented the anatomy very well. So I'm going to go through this quickly, the part which he's already covered. This virus is basically, as Dr. Sana Khan has mentioned, is something called a coronavirus, COVID-19, SARS-CoV-2. And the reason it's called coronavirus is because it looks like a crown and you can see the spikes. So that's why the name came. And these are the Ace receptor, which Dr. Sana Khan mentioned. Now, these viruses are not new. They have been in existence for ages. We can see these are viruses in cats, cattle, camels, and the way we get it, this is possible mode of transmission, bat, and there's an animal called pangolin, and this is how zoonosis happen, and we get the virus after exposing to these animals, after inhaling them. So droplet, which is coughing, sneezing, speaking, and then you start transmitting it. So this is one way, but right now, as you know, there's a lot of theories out there that it was made up in the lab, and there's some other things that are also being proposed. So, but this is the most likely mechanism. One other thing about this virus is we had these pandemics in the past, which was MERS and SARS. They were the same family, and this is just a different mutation of the same family also. So right now, where do we stand? At this point, around the globe, we have 213 million cases, and people who have died, unfortunately, more than, as you can see, 4.4 million cases, and the people who are recovered, almost close to 200 million. USA, almost 40 million cases. Unfortunate death, close to 650,000 cases, and this is the recovered. If you want to understand this disease, you need to understand and compare it with influenza, which we see it all the time, right? So every year you get the shot, because we are all concerned that you can get very sick, you can die. So what are the numbers for influenza? This is from 2018 and 2019, 35.5 million illnesses, 16.5 million medical visits, 490,000 hospitalization, 34,200 deaths. Look at over here, 650,000 deaths and 35,000 deaths with flu. So there's no comparison between COVID-19 and flu. This is a deadly virus. So we have to follow all the recommendations that CDC has been recommending, what Dr. Sana Khan has mentioned, and other healthcare physicians have been mentioning. So what's happening with the daily case? So we are standing here, look at the graph, very smooth. We are going up, we are not going down, we are not plateauing, it's just keep going up. This is a deadly virus. And you can see when this thing started, over here, this is the first wave, which we were all scared. The whole city was shut down. And this was the real wave, which happened in December, January, and February. And then this is the third wave, and now we're in the fourth wave. So right now, we are actively in the fourth wave. So the cases are continuously rising. All the states which are unvaccinated, which include Florida, most people are unvaccinated, that's what I mean. Texas, Mississippi, Louisiana, and southern states. This is just to compare different diseases, which include heart disease, cancer, flu, Asian flu, car crashes. But when the spike happened with COVID-19, there are more cases of people infected with COVID-19 than heart disease or cancer. So this is a real issue that we are dealing. This is a real pandemic. Initially, it was the pandemic of everyone. Now it's the pandemic of unvaccinated in US. Outside the US, obviously, it's a different story. So this is a chart explaining the number of deaths. As you can see, the graph continues to go up. It's not plateauing. It's not coming down. It just keeps going up. In spite of having Pfizer, having Moderna, Johnson & Johnson, AstraZeneca, Novavax, Chinese vaccine, Sputnik V, still there are more people dying every single day. And this is what's happening right now. Means initially there were less death, unfortunately, than in December and January. That was the worst. Then later on, the numbers went down, and now again the numbers are going up. And if you go by state, then the numbers are completely different. So this is what we have so far learned about this virus. It's a brand new virus, so every day things change, every month things change, so we are learning about it. Initially, we named them B117, 1351, P1, B16172, and they were named British variant, Brazilian variant, South African variant, Indian variant, and later on, the names were changed to Alpha, Beta, Gamma, Delta, and Lambda. The reason was because people start using the name of the country and then start blaming the country, which is not the case. This is a virus which once gets into your system, start to mutate, and it can happen here in US, it can happen in LA, it can happen in Chicago, it can happen in Singapore, it can happen in China, Pakistan, wherever the virus is. So that's why the name was changed. And the Lambda variant is originated in Peru. So what do we know about the vaccine and the viruses and what's happening right now? Okay, I think, let's see, okay. I pressed the wrong button, sorry about that. So this is what's happening right now. The case count continues to going up. That's happening as we are talking. But good news is people who are vaccinated, 101 million people vaccinated, that's a breakthrough infection, 10,262 cases of breakthrough infection, and these are mild cases. So vaccine works, not 100% effective, but more than 90% effective. So that's good news. What are the risk factors and who should be concerned? People who have these health issues, hypertension, diabetes, obesity, heart problem, heart failure. This is a big problem. We see this every single day. People who are overweight get this virus very easily, and it's very hard to keep these patients alive, especially in ICU. It's just very hard to keep them alive. So this losing weight will help you protect from other diseases and also COVID-19. And elderly people, male, and as I mentioned, with the minority group, which is Hispanic and African American. Some of the symptoms that you already know, I'm just going to go through them really quickly. Fever, dry cough, shortness of breath, nasal congestion, flu-like symptom basically. And so you have to watch for those, which we know by now by heart. This pandemic has been with us for almost 2 years. So these are some of the common things that we are seeing, which is loss of taste, loss of smell. Now with this Delta variant, what we are seeing is people come in with complaints of abdominal pain and diarrhea. Diarrhea is very common nowadays with this thing. And as you can see, vomiting, chills, rashes, this is also can be seen. So what's the course and the disease course for this COVID-19? After you get exposed, you have 5 days. So during those 5 days, you don't have that many symptoms. You're completely functioning fine. You're going out, meeting friends, having dinner, but you're shedding the virus, as Dr. Sana mentioned about the viral load. So this is the time frame when you are spreading that viral load, and then you start having the symptoms. So at day 5, the first symptom usually starts. So usually I would say 1 week, at that point you will start the symptoms. And if things got unnoticed, by 2 weeks you'll end up in the hospital. And if the good news is, if you have mild case of COVID-19, the chances of you having recovery, full recovery, no long-term complication, is very minimal, very, very minimal. But if you run into the severe case, then it's a different story, and we'll talk about that. And basically, this is talking about antigen PCR testing, and then now there are over-the-counter tests which are available, and there are apps which are available, which you can download through CDC if you got exposed, and what to do next. So regarding the testing, over-the-counter testing is available for people who have to do more frequent testing, and it's requirement for their job. But otherwise, the PCR is the better test. And then if things go out of control, then you go into something called ARDS, which Dr. Sanam explained very well about the anatomy. And there's the term, it's adult respiratory distress syndrome. So exactly what he talked about in the alveoli, what happened to the surfactant cells and both type 1 and type 2 cells, it leads to this problem, which is ARDS, and it's very difficult to control, very high mortality. Not because of COVID-19 just per se. If you develop ARDS due to any diseases, it's not only COVID-19 which causes ARDS. So it's very hard to ventilate them and keep these patients alive. So these are the organs which are mostly impacted with the COVID-19. This is the route of entry and the organ which is mostly impacted. So that's why pretty much every COVID-19 patient that comes to the hospital, ER, I'm usually involved. And as you can see, these are the changes which was discussed earlier in the lecture, which is extensive edema, hyaline membrane formation, microthrombi. And these are just the medical term. It's just your lungs become stiff, and you can just, for layman, it's like a cement. There's no gas exchange. In a normal scenario, you should have a spongy form of lung, like say, just like a sponge that you use for cleaning dishes. But in this case, once COVID-19 hits you and you have ARDS, that sponge turns into a cement, and there's no gas exchange. So this is an organ which is 100% involved, which we see in every COVID-19 patient. And the other organ that, interestingly, that we see is the kidney. Kidney gets affected pretty quickly, and a lot of these patients get onto hemodialysis, or which is an artificial way of filtering the kidneys, or CRRT, continuous renal filtration. And one other thing that we are seeing is stroke in these patients. So these things that we are seeing pretty commonly, heart attack, not that much, but we still see it. And rest of the things, we see it on and off. But this is the main organ which is impacted. And then after that goes the kidney, and then the brain. This is what we see every day. So this is just the pathology of what was discussed in an earlier lecture about different cells, how the membrane changed, and what happened to the lung after invasion of all the cells and debris and extra fluid in different parts of the lung. So this is how it looks like. And there's no need for you to understand this. This is just to get you an idea how the lungs change. So some of the basic things that we all should be doing every single day. And this should not change unless this virus by magic is gone. We should all be washing our hand, because shaking hand right now means we can easily transmit Delta virus. There's no question. Means if we shake hand today and someone is asymptomatic, we can easily get the Delta virus. Wear mask, as Dr. Sana emphasized earlier, how important it is. I mean, this will protect you immensely. This will protect you immensely, you, not you. And also, if you are sick and if you are in that phase of first 5 to 7 days where you're not showing symptoms, but you have the viral load and you can infect other people. So it will save me, protect you, and protect your loved ones, and especially elderly family members, parents, grandparents. So young kids, not that much. And then distance. So obviously, the far off you are from each other, we're better off, you're more protected. And these are just to give you some idea about how to live your life when someone gets infected. So, I mean, this is pretty extensive. I mean, I can always share the slide with you guys, but how to limit the contact, how you should be doing the cleaning, like cleaning the room, staying separate, how to do laundry, because these are just basic, simple things which can really protect you and your family. But sometimes we just get careless, or sometimes we just don't think about these things. Now, talking about all the clinical scenario and the symptoms, now what can we do about the virus? As this is a brand new virus, just like give you an example about HIV. When HIV came, it was a big problem for all of us. We didn't know how to handle it. We didn't know what to do. And as the time passes, in over a period of 30 years, we have a lot of new treatment and people with HIV disease living a normal life. So this is a virus that we are trying to understand. And there are a lot of things that we have learned about it, and we have tried multiple medication. Some of them have been failure, some of them are success. That's how the research goes. So it's not going to be 100% success. Usually it's more failure than success. So these are the drugs which we are currently using. One is Decadron or dexamethasone or steroids. And that's a very proven fact that is effective. Then this is an antiviral drug which has been used for Ebola, and it was tested for COVID-19 and showed some efficacy. These are the monoclonal antibodies, as the same kind of graph was shown earlier, and the monoclonal antibodies work the same concept, but you just give it through IV access, and it is injected into your system rather than your system producing it. And then this is the blood thinner. We think that there's a lot of clotting formation because of this virus, and that's why we try to use the blood thinner. Plasma from infected patients, that has been tried in severe cases. It did not work initially. When this whole concept was brought up, we were using it a lot, especially I would say last year around March, April, May, June, July, but it did not show much efficacy in severe cases. But mild cases, there's some data coming out that it may be effective in mild cases. Mild cases means, like, say, one of you having a body ache, flu-like symptoms, fever, chills, and just not feeling good. In that case, we can give infused plasma, and that will protect you from getting into the severe phase. So you want to stay away from the severe case of COVID-19, because once you reach there, then the chance of survival is less. This is one of the HIV drugs which have been tested, and Actemra, which is used in rheumatologic diseases. So just to start with, this was about monoclonal antibodies, which was used by our past president, Donald Trump, and he got released from the hospital within 48 hours. So I'm not the radiologist, neither an expert as Dr. Sana Khan, but I see X-rays every day on every single people. So if I see 40 to 50 patients every day, then I see 40 to 50 or 100 X-rays every day, and I've been doing it for 20 years. So, so any help, obviously, from Dr. Sana Khan is always appreciated. So this is a normal X-ray, and this is what happened in patients with COVID-19. As you can see, it's that white fluffy stuff. So the lung is getting damaged. There's fluid getting into the lung because of inflammation and all the cells which are migrating towards the lung. And this is another worst case of lung getting damaged. And this is what we call ARDS. And this is a CAT scan. And as you can see, the normal lung should be black, not white. The normal lung should look like this. And this is all abnormal. This is a severe case of ARDS. What you can see, COVID-19 causing significant lung damage. Now, after the treatment, what saved life? A vaccine saves life. So I'm going to keep repeating this: vaccine saves life. And if any of you have not received their jab, they should get it today, tonight, tomorrow. You can get it from any place, Rite Aid, CVS. You can go to your doctor. You can go to the hospital. It's ample amount of vaccine which is available, and it is really protective. And these are the different forms of vaccine which are available. You don't need to learn about them, just need to know that these are different methods that these vaccines are prepared. Nucleic acid vaccine, inactivated vaccine, viral vector vaccine, and with protein. As you can see, Moderna, Pfizer, CureVac, Inovio, Sanofi, they were made through messenger RNA. They're manufactured in the lab. This vaccine, which is a Chinese vaccine, Wuhan Institute, Sinovac, it's basically uses a killed version of the virus. So this is manufactured in the lab. So someone is actually using the genetic code to produce the messenger RNA, and the messenger RNA is going to get into your cell and start acting the same way as we discussed earlier, how the body reacts. So, and this is by giving your body a dead virus, a dead COVID-19. And then this is another viral vector which carries, and it basically, these are the AstraZeneca, CanSino, J&J, they use the same method. And Novavax, which is a brand new vaccine, it's not FDA approved yet, but the data was published almost a month ago. It's almost 90% efficacious, and it may be used as a booster too. So I'm expecting that this should be approved by December. It's a small pharmaceutical company on the East Coast working with South Korea. So these are just to give you, initially when the vaccine was in the works and we were working on the vaccine, there were almost 200 pharmaceutical companies in the hunt. So these are just example, and I forgot to mention about Sputnik V, which is a Russian vaccine, and that was named after their this was named after a space a ship that they, I think, sent it up probably in 1960s. And that's also, according to them, is effective. So what does messenger RNA vaccine does? Nearly 4,000 healthcare personnel, first responder, essential workers were tested weekly for the virus that causes COVID-19. And those who were fully vaccinated were 90% less likely to get infected. So this is just to give you one more surety and example that this is a very effective vaccine, both Pfizer and Moderna. And those are messenger RNA vaccine, and they are built in the lab. Vaccination, this is a little bit of an older slide, but Israel is still doing very well with the vaccination. US is catching up, and these are the other countries which are doing better. So what's happening right now in US? California, we are here, almost 60%. Hawaii, 67%. Vermont, 70%. And look at over here, Mississippi, 34%. Louisiana, 35%. Texas, 44%. And then Florida, 50%. So this is the belt where we are having a major pandemic of the unvaccinated. So Texas, hospitals are full, ICUs are full, ER is full, there's no beds. Florida, Louisiana, there's nothing available. I mean, they have no staff, there's no beds, and they have made up ICUs and made up hospitals. So this is a major catastrophe that's happening right now in US, and it's coming to us also in California too. And we are seeing a major surge, which a general, means our a regular community member is not able to see what we see every day. So US, almost 190 million people have been vaccinated. That's 57%. 163.9 million people, or 49% of total population, have been fully vaccinated. So close to, I would say, 190 to 200,000, 200 million US population is either received one jab or two jabs. Pace of COVID-19 vaccination has steadily risen because of this pandemic of the unvaccinated. Before that, we were pretty slow, and everyone was thinking that they are immune, they're protected, they're not going to get infected, especially the younger generation, which is the age between the ages of 18 to 35. They think there's nothing is going to happen to them. And now, after our discussion, as Dr. Sana Khan, remember, we had a discussion with even some Congress representative and other elected official about pushing for booster doses, because what we have seen, that the antibody response or the efficacy of the vaccine is slowly coming down. It's probably, I think, if you receive the vaccine in December, January, or February, antibody level probably is around 66, 65%. So we started with 94, 95%. So we, and especially the healthcare people, personnel are significantly exposed and they're very high risk. So this is a really important decision made by the government, and you will be able to get your booster if you're almost 8 months out, September 20th. And also people who are immunocompromised, there are a number of studies after the first shot, 15% antibody response, then between 30 to 50% antibody response after the second dose. So in the immunocompromised population, which I'm talking about, people who have lung cancer, people who have lupus, who are on immunocompromised medication, which could be methotrexate, prednisone, you can get a third shot in that population after the second within 28 days. So at 28-day mark. So third dose for immunocompromised and booster for general population. So this is something that we all should know that's available, and we should avail it if we want to protect our loved ones. Post-exposure prophylaxis. This is if you get exposed to someone and you have mild symptoms, as I mentioned, monoclonal antibodies can be used, and they're effective. And most of the emergency rooms have these available. So this is what I already talked about the third dose and the booster. And this is just for reference. Now, why, I mean, say we have 50 people sitting here, and 30 says, okay, we have the vaccine, 20 says we don't have vaccine. So looked at the data, and some of the reasons that people who don't want to get the vaccine, concerned about the possible side effect, plan to wait and see whether it's safe. So they want to see, if I get the shot, if I'm going to get sick, I'm going to get a heart attack, I'm going to have a stroke. If not, then they will be willing to. So that's one more reason. People need it more. They need more information. They don't trust the COVID-19 vaccine. They don't trust the government. So there's not much you can do about all these things. Don't like the vaccine, concerned about the cost. That's not an issue because it's freely available, and doctor has not recommended. That's not the case. Now, what's happening with the vaccinated and unvaccinated, I think this will be really important for people who are not vaccinated to understand and get the vaccine jab. So this graph is basically showing three different groups: unvaccinated, partially vaccinated, and fully vaccinated. Look at the fully vaccinated. No issue at all. Literally no issue at all. Partially vaccinated, there is some protection that we know. Not 100%, but still better than nothing. But look at the unvaccinated. This is what's happening in US right now, which is literally not needed. We have treatment which can protect us. It's not the treatment, it's preventative treatment. And it's a good weapon that we can use against this virus. This is July in Los Angeles. So we live in LA, right? So unvaccinated have 5 times more COVID-19 infection than fully vaccinated. Unvaccinated have 29 times more COVID-19 hospitalization than fully vaccinated. And this is actual fact. This is true. And this is what we are seeing every day in Orange County, in Inland Empire, and Los Angeles County. So these are just some of the data that I'm going to go through quickly. So God forbid, if any one of you gets sick, you go to the office of the doctor's office, get symptomatic treatment, go home, or telemedicine. But if you end up in the hospital, if you're on a regular ward, you do well, you go home. But if you end up in the ICU, what will happen? These are some of the risk factors which were looked in Italy. If you will end up in ICU, if you're a male, if you're old, if you're requiring increasing amount of oxygen, normal amount of oxygen that we are breathing right now is 21%, which is in this room. So these patients end up requiring 100% oxygen, 100%. Like that's the maximum capacity that we can deliver. Even then, we cannot oxygenate these patients because their lung is so damaged that there's no air exchange. Okay, I think, let's see. Probably, I think I'm missing a few slides, but so I'm going to go over here. So I'm probably missing a few of the slides. So let me go over what happened in the ICU. So if you end up on the ventilator, if you end up in the ICU, we are seeing close to between 50 to 80% mortality. So your chance of survival is 1 in 5. So if, say, 5 of you end up in ICU, which I hope never be the case, 1 will survive, 4 are going to die. And right now what we are seeing is ages between 20 to 50. That's the age range that we are seeing. And I have a number of young patients on the ventilator, and some of them are not going to survive, which we can see. So this is not looking good. One thing that we can do, if someone young who get really sick comes to the hospital, get admitted to ICU, we can get them on the heart-lung machine, which is called ECMO machine. So there's a whole criteria, and that can sometimes help them prolong their life, and we can keep them alive and they can survive. So that's heart-lung machine, or ECMO, is available in centers like UCLA, Cedars-Sinai. UCI also have it. So there are only few places, UC San Diego, UC San Francisco. So we have to fly them to all these high acuity centers. So at the end of the day, avoid crowded places. So we're still not out of the wood. I think with the way pandemic is acting and the way the virus is mutating, I think we are going to be with COVID, as Dr. Sana Khan mentioned, for some time, at least 2022, 2023. Some normalcy will arrive in 2023. And moving forward, we should be getting these booster shot every year against COVID-19. And we should follow all these precautions, at least for now, because the pandemic is pretty bad. So avoid any crowded places. I mean, if there's no need, then please avoid it. Wear a face mask, social distancing, hand washing, as we talked about how to keep your rooms clean, someone who's sick. Vaccine, this is 2020 because the vaccine was actually approved, emergency use authorization in 2020, and now FDA approved the Pfizer vaccine. So emergency use authorization is that this the specific or particular medication is getting approved because it's an emergency, it's a pandemic, and we have some information available. So the government allows you to use it, keeping in mind there may be consequences. But when the FDA approves it, then that goes away, and the FDA will list that there are like 10 side effects. Those are possible, but otherwise it's safe. So, and then in the hospital, oxygen, this is the most important treatment. And then Decadron, Remdesivir, Actemra, blood thinner, Lovenox. This is all in the hospital. As an outpatient, we can use monoclonal antibodies. And the good news is most of the cases are mild and they get better on their own. But if you end up in the hospital, if you end up in the ICU, the chance of survival is 25% or less, especially if you're in ICU. So this is a serious problem, and I'll be happy to answer any question and take it seriously. If you haven't received the vaccine, get the vaccine tonight, tomorrow, day after tomorrow, and take it seriously and don't take it casually. Younger generation, younger population, college kids, please take the vaccine. You're not immune. And if I will show you the people who are in your age group and they're dying, you will be scared. Thank you so much for your attention.
Well, thank you so much, Imran. Honestly, I mean, I think, there's always going to be some controversies. There's going to be some people that are anti-vaccine and whatnot. If you are anti-vaccine, or if you don't want to take the vaccine, let me highly recommend, please follow these rules. If you're going to have events, outdoor events. If you're going to play sports, play outdoor sports. I think that, there is certainly logic if somebody says to me that, oh, we don't know the long-term consequence of these vaccines. We don't understand the consequence or we don't know much about this. We want to see it. I'm not going to argue with people. All I can tell you is the data is pretty clear right now in terms of those that are in the hospital and those that are not. So if you still choose to not have the vaccine, then I think it's really important that you still do your very best to avoid the virus as best you can. So any questions that you guys? Yes.
So why people who are exposed to COVID-19 need to be vaccinated?
Oh.
It's a really good question. People who are exposed to COVID-19, why do they need to be vaccinated? So, I mean, this is a pretty much everyday question that I have in discussion with my patients. So once you get infected, you'll have an antibody response, but it's not enough that it will protect you, and the antibodies will not stay in your system for that long. Maybe for a few weeks, maybe a month or two. So that's why you need the vaccine. So it's not 100% protection. So if you are not vaccinated, you get infection which is mild, you get a little bit of response, and then next time you'll get COVID-19 infection, it can get severe infection and you may not get another chance of surviving. So if you think that getting COVID-19 in your system and getting infected, you're protected, but that is not the case. That's completely false information. You should get vaccinated. Infection will not protect you. And I have patients who have been infected multiple times, but they were not vaccinated. And even vaccinated patients have breakthrough infection, as I showed it to you, but you can see it's like less than 2%. Thank you.
So let me answer that in a different way. As I said to you earlier, viral load is absolutely the critical element. So let's just say that you got COVID-19, you developed some antibodies, and even if your antibodies went down to 20% versus the 90%, okay, it is still sufficient if you have a small viral load. But if somebody sneezes on you or coughs on you, or if you put your hand somewhere where you just picked up a large amount of the virus and you're touching your nose and hand and face, you're going to be exposed, and it's very difficult to fight this virus right now because of its multiplication rate. It really does multiply faster. In fact, Delta, I've heard, is about 1,000 times more viral load in people's in nasal passages and whatnot that they have seen. So it's very tricky. Yes.
I have a question. I had last month, I was exposed to COVID-19 myself, as you know, Dr. Sarah. So, how fast, how quickly you recommend me to take the vaccine after 2 months, 3 months, 2 months?
So if you were exposed and you didn't have any symptoms, you did have the symptoms.
My case it was my case it was very light case because I never lost my taste or I never lost my smell. And at the same time, I didn't have fever at all. But I suffered like in the joints, in the muscles. I have the first 7 days, 10 days when I go for stairs to go to my apartment. I used to go 1 minute and when I'm healthy. So when I exposed to it, like 45 days ago, so I have each 2-3 steps I have to start, and I was having difficulty on my muscles and having a short.
Basically, you were exposed, you were positive for COVID-19.
Yes.
And the question he's asking is, when should I take if we're
But
taking
right now
vaccine?
I'm negative, I take red of it and I'm negative. So they told me, the doctor told me, you have no problem for 5 months, he told me. But you can take the vaccine after 2 months, 3 months. But he recommended me to ask doctor or specialist.
Yeah, I think it's a good question. You have very mild symptoms, and just to reinforce all the symptoms that you were having, the shortness of breath, that was all because the COVID was damaging your lungs. Not to that severity that we talked about it, me and Dr. Sana, but it was causing the problem with your lungs, and that's why you're short of breath. And so the simple answer to your question is a month will be a good enough time that you can get the COVID vaccine. Yeah, month, yes. Month will be good enough time.
We have to, it's Isha time.
Okay, so thank you.
No, well, thank you so much, Imran. I really appreciate your expertise and teaching us, and hopefully there may be. I'm sure there's going to be questions that are going to come in, and we may just throw them at you later on, so you can answer those. All right. So thank you very much. Inshallah. Oh, you're very welcome. Inshallah. It is very important actually to be educated about it and make educated decisions, right? So with people, there's emotional decisions right now, there's political decisions being made, there's all kinds of unknown decisions being made. You can make your own decision, but at least be informed about it so that you can in fact make what's called informed decision. So inshallah, have a wonderful evening, and we'll see you next time. Assalamu alaikum.